Hi, everyone. Good morning. Welcome back. We're joined today by Dr. Eddie Stenehjem to give our weekly COVID-19 update for the community in the state of Utah. Dr. Eddie Stenehjem, thank you so much for joining us. We really appreciate it.
Thanks for having me.
I want to start this live a little bit differently than normal. Can you just go over your credentials for us really fast and what makes you an expert on this specific topic? I know that you've been doing this with us for the last almost year at this point, but if no one's watched these before, what do you do for a living at Intermountain Healthcare?
I am a practicing infectious disease physician, and I'm the medical director of antibiotic stewardship for the organization. So my role in that leadership role is to really try to get our physicians and APPs to utilize antibiotics in the most effective way to reduce any kind of development of antimicrobial resistance and also minimize harm to patients. So I trained in infectious disease at Emory University in Atlanta. That's also where I got my master's in clinical research, and then was recruited here to Intermountain in 2012. And so I've been here for the past 8 years. And been in this leadership role for the past 5 approximately.
And as far as COVID-19 goes, you've kind of been involved with this since the beginning when it first came to Intermountain Medical Center. Is that true?
Yeah. So infectious disease physicians across the US, across the world, have been actively engaged in management of COVID-19 from the beginning, from when we started seeing this really become a major issue in China in January, and then following it through, obviously, till present day, and helping advise the healthcare organization in terms of how to best manage this epidemiologically, helping advise the Department of Health when they have questions about it. And then it's our group also that develops the treatment guidelines for COVID-19 inpatients and outpatients. And then we have other infectious disease experts that run the microbiology lab, which is set up for our testing. And so our group of infectious disease physicians across the organization has been very intimately involved in COVID-19 for the past year now. It's crazy. It's been a year.
It is crazy. It's been a year. Well, thank you for that. We're going to get into case trends and what's happened since the last time we've spoken. Our total case counts in the state of Utah are 292,720. Our case counts yesterday were 3,769, which brings our 7-day rolling positive average to 32%. We have a total of 1,330 deaths in the state of Utah, and yesterday there was 18 reported. Our hospitalizations are at 11,463, with the daily amount at 525, which brings our referral ICU capacity percentage to 88.5%. Our vaccine rate is also now at 60,462 as reported yesterday. Let's break that down a little bit. Those hospitalizations seem a lot higher than yesterday or last week, as well as that positive rate. What does this mean for the community?
Yeah, I mean, I think let's take a step back and first talk about cases, and then test positivity, and then hospitalizations, and then ultimately death. What we're seeing now is a significant trend up in terms of our total case counts. If you look at the past 2 days, we certainly have seen a rise in cases with kind of similar amount of testing as well. And so we're definitely seeing more cases detected, across the state. And the challenge is that we're seeing this test positivity be very, very high. It's one of the highest in the nation. And so, on average, 32% of people that are getting tested are positive for COVID-19. And that tells us a couple things. One, it tells us that the community transmission rate is sky high. And it tells us that we're probably under testing. In the fact that if we're having that many people positive, we really need to be testing more people to really get a better handle of what's happening with this epidemic here in the state of Utah. So as we know, as cases go up, there's a delay, typically a 7-day delay or so, 7 to 10, and then we start seeing increases in hospitalizations. And that's what we're now seeing, is that we're now starting to see this tick up in hospitalizations, both on the state data and then also on Intermountain's internal data. When we look at what how many people across our hospitals are in the hospitals because of COVID-19. We had this trend, just like the state, come down, and now we're starting to see it go back up. And we're now getting particularly tight in certain regions. And again, we're having to make sure we load level aggressively. And I suspect that, this is the Christmas and New Year's surge. This is exactly what we expected. We had hoped that our hospitalizations would have come down even more, gotten down to a lower level, and then we would have more room to accommodate this surge. And unfortunately, that didn't really happen. We definitely did have a little reprieve, got some of the patients out of the ICU and the floors, but now we're just starting to fill back up again. And so we're also seeing that in the capacity being, now we're at 86, 87% capacity, which again is over that threshold of 85% saying we are full. And unfortunately, we anticipate that this surge will continue, and we'll start seeing more and more cases, which is going to lead to more hospitalizations. And as we know, it'll eventually lead to more deaths, because that's what naturally follows these hospitalizations, particularly the ICU admissions.
And how is the...
Sorry,
go ahead.
The one thing I should mention too is that, something we track internally within Intermountain is the percent positive of our asymptomatic patients. And so patients that are coming into the hospital for a procedure, whether it be they're coming to get an elective or a non-emergent surgery, if they're coming in labor, or if they're having a scheduled outpatient procedure and endoscopy of some sort, we're testing those people prior to that procedure. And what we're seeing within our data is that among those asymptomatic patients seeking care for one of those procedures is that our asymptomatic positivity rate is going way up as well. It's actually been increasing steadily in a linear fashion since October. And so we're continuing to see really high rates of asymptomatic positivity amongst those patients. And so what does that mean? That just means that the community transmission is continuing to rise. And we're continuing to see really high rates of asymptomatic infection picked up in this pre-procedure screening.
I want to break down asymptomatic a little bit more. We've gotten a lot of questions around asymptomatic and pre-symptomatic spread and what that means. And I'd love to just break that down. First, I want to start with the two different terms. What does asymptomatic mean and what does pre-symptomatic mean?
Yeah, so people that are asymptomatically infected are infected with the virus. It's detectable by our lab test, but never develop symptoms. Okay, so you'd be feeling completely normal, going to work, whatever it might be, completely asymptomatic, but have an infection in their upper respiratory tract with the virus. That's asymptomatic infection. Pre-symptomatic infection means these people are also without symptoms for now, but then develop symptoms in the coming days, typically the next 2 to 3 days. And so pre-symptomatic means, yes, you are asymptomatic, but then you become symptomatic. And so these are people that are infected and have yet to show signs or symptoms of the infection, but they eventually do develop signs or symptom infections. And then asymptomatic are those that are infected, but never develop symptoms at all.
And I know you talked about the percent that we are seeing, that 13% asymptomatic spread. What about worldwide or even just in the US? Is there a pretty good indication of those two things happening, which is causing some of this community spread to increase?
Yeah, so we don't have any either national or global numbers on what is that percentage, because most healthcare organizations, states, nations have different procedures and processes and how they evaluate asymptomatic individuals. And that's really dependent on test availability. And so people that have very high amounts of test availability are able to test asymptomatic individuals at will, as much as they want. In states that don't have as much test availability, they aren't doing as much asymptomatic screening. And so we don't know, what that national level is. That said, we know that asymptomatic infection and pre-symptomatic infection definitely leads to transmission and leads to infection. And so there's been a number of studies. The Diamond Princess cruise ship is one, the outbreak that started in Seattle in the long-term care facilities, another. There's been a host of other different studies that have looked at this and shows that yes, indeed, asymptomatic or pre-symptomatic individuals definitely lead to transmission. When you think about the viral burden in somebody that has symptomatic COVID-19, your viral burden is actually the highest between the 2 days before symptoms start and the 2 days after symptoms start. And so you are very, very contagious in that window before symptom onset and then immediately after symptom onset. And so this is the reason why mask wearing is absolutely critical, because you could be out at the grocery store, you could be out with friends and families, and if you're not wearing a mask, you could be in that pre-symptomatic period and be transmitting the virus unknowingly and then develop symptoms the next day, for example. Asymptomatic infection, same deal. You have no idea that you're shedding, and that virus is transmissible. So these are the reasons why mask use is absolutely 100% required, and social distancing, hand hygiene, and are all very, very important in preventing this transmission.
Along those same lines too, if you know of a known exposure, or you're contacted or someone lets you know, why is it so important to get tested then if you've been exposed but you're not necessarily showing symptoms?
Yeah, so knowledge of whether or not you're infected or not is incredibly important. So if you have a high risk exposure, you have a couple options. One is you can go into quarantine, meaning you lock yourself in the house, maybe not lock yourself, but you isolate yourself to the house and you wait to see if you develop symptoms, and you do that for 10 to 14 days. Okay. The other option is to go out and get tested. So you actually know whether or not you're infected. And some people are doing now this test at day 7 post exposure. And if you're negative, then you can come out of your quarantine period. The main point we should emphasize though is after an exposure, going out and get tested the day after or 2 days after, not going to be beneficial. You have to have time to let the virus incubate to be able to detect it in your upper respiratory tract. So testing 7 days after exposure, absolutely important. If you're infected, and if you're infected, you can then go ahead and self-isolate. And if you're negative at day 7 and don't have any symptoms, you can come out of quarantine at that time.
There's a really good article too that you shared with me earlier that I will put into the Facebook Live for people to look at that just kind of breaks down asymptomatic spread a little bit more if someone is interested. So I'll leave that for people. I want to talk a little bit more about this holiday surge. We talked about it last week. We hadn't really quite seen it yet, but are we seeing it now? Is this a holiday surge potentially from New Year's Eve? And what can we potentially expect to happen in the next couple of weeks?
Yeah, without doubt, this is a surge from, I would say, the holidays, starting from December 24th, going through New Year's. Yesterday, January 5th, or the data I'm looking at here is from the Utah Department of Health. January 5th data is 3,700 cases reported. The day before that, almost 3,000 cases reported. If you look at the trend line, it's going back up. And this is occurring exactly, 7 to 14 days after that holiday season, really started. We're also seeing the patients in the hospital presenting with stories of, I had a holiday gathering. A couple of days later, somebody got sick. So they were in that pre-symptomatic phase. And now we're seeing older people getting sick, having severe complications, having to get admitted. And so it's those high risk individuals that we're seeing now having turned positive from exposure at the holidays and now requiring hospitalizations. And so what we're going to continue to see is we're going to continue to see that rise. Now, it's really how long we see that rise is really dependent on what people do and revert back to after the new year. And so people revert back to their social distancing practices, the not gathering outside of your family. If they revert back to that, we anticipate to see those numbers to come back down. Add on top of that, the fact that we're vaccinating more and more people, that will allow that number to come down faster. But we anticipate that the month of January is going to be pretty rough from a hospitalization capacity standpoint, because that's really the time period we're going to be dealing with this in the hospitals. And that's assuming that we have reverted back to our practices of social distancing and mask wearing after the holidays to be able to bring that number back down. So I suspect January is to be a pretty rough month, and hopefully it'll be limited to January. And so we can then kind of get the hospitals moving, getting the wards a little more open, and then we can vaccinate more and more people.
I want to talk about vaccines now too, and just bring that topic up. You got your second vaccine dose this week. How did that experience go? Do you want to just kind of give us an update?
Yeah. I mean, so the actual experience of getting the vaccine, it's been really pretty slick. I would say Intermountain has, really kind of learned quickly in terms of how to get thousands of healthcare workers in and out and get their vaccine done efficiently. So I got an email that said, hey, you're due for your second dose. Here's your time window frame. Make sure that you schedule it where you have some time off, or you're not, needed in clinical duties for 24 to 48 hours after your second dose. I was able to pick my location, showed up at 7:05 for my vaccine, had the vaccine in my arm by like 7:15, waited the prerequisite 15 minutes, and then left at 7:30. And so went really well, just the timing of it. We know that the second dose of these RNA vaccines is much more reactogenic than the first dose. And so we are making sure that people are aware that it is normal and can be expected that you're going to have more symptoms after the second dose than the first dose. And that's why we really emphasize that, one, they're knowledgeable about it to know that, hey, these are expected. And two, that we make sure that after that second vaccine, that they've got some time off and they're not necessarily expected to be on clinical duties. And so we're not short-staffed. Okay, so my second dose was more reactogenic than the first dose. After the first dose, I had a sore arm, maybe a little fatigue, but it was pretty minimal. I would say I was not, affected by it really at all. It didn't affect my life whatsoever. After the second dose, no problem for 12 hours. Started to have some arm soreness that evening. I did start getting some chills that were more significant than the first shot. And then I did have a fever that night. And so throughout that night, I had chills and fever. By about 4 a.m., 5 a.m., fever had broke, chills had stopped, and I was able to get more rest. So it definitely was more reactogenic than the first. When you look at the data, and particularly in the Pfizer vaccine, but the Moderna vaccine looks similar. And remember, that data is online. It's freely available to everybody. It's in the FDA application. Go ahead and take a look at it. Fatigue was in 59% of the people that got the second dose, compared to 23% in the placebo. Okay, so significant difference. And this is in the 16 to 55-year-old age group. Headache was in 52% compared to 24% in the placebo. I'm looking at the study right here. I don't have these things memorized. And chills was in 35% of the people that got the active vaccine compared to 4% in the placebo. And so, incredibly common to have fatigue, headache, and chills. And fever was in 16% of those people getting the second dose compared to 4% in those getting the first dose. So these are expected side effects. People should expect to have them. And they can be managed with Tylenol and ibuprofen. And after the second dose, it's just really important that you give yourself some time where you're not expected, to be at work or care for loved ones and those types of things. And so it's just something to be aware of and know that they potentially are coming.
That's a great recommendation as far as just making sure your next day is kind of as clear as possible in case you do have any type of reaction. I want to talk about how, sorry.
You also mentioned that the person's response to the second dose is incredibly variable. Yesterday at the news conference, we heard from 2 nurses that got their second dose and had arm soreness, and that's it. I had a friend who is a physician that got his second dose the same time as I got mine. I talked to him yesterday, like, hey, how did you do? And he's like, I had some arm soreness, but no other side effects. And so it's incredibly variable in terms of the side effects of the vaccine. It should be noted, though, that if those symptoms persist after 48 hours, it's really important to get tested for COVID-19. It definitely is a chance that you're getting vaccinated at the same time as that you're in that pre-symptomatic stage and develop symptoms of COVID-19. And so if those symptoms last for more than 48 hours, you absolutely need to get tested. And if your side effects include sore throat, shortness of breath, cough, loss of taste or smell, those aren't vaccine-related side effects. Those are symptoms of COVID-19 and absolutely warrant testing. And so you have to be able to differentiate that. Are these vaccine-associated side effects, fatigue, chills, fever, muscle aches, or are these symptoms of COVID-19, sore throat, cough, shortness of breath, decreased taste or smell, and be able to kind of navigate that. So something for us to all be aware of and educate to.
You brought up a really good point. So you got your first vaccine around 3 weeks ago, and now you have your second one. Is it possible to contract COVID-19 between the first dose and the second dose? It sounds like yes.
Absolutely, it is. In the study, they look at what is the efficacy of the vaccine after the first dose, and it was high 50%, 57%, I think. But keep in mind that only took you to day 21. In that study, they vaccinated everybody with 2 doses. So we don't know what the long-term efficacy of 1 dose of the vaccine is. It was only 57% in that initial 21 days after the first dose, but we have no idea what it is long-term. So absolutely, it is possible to contract COVID-19 in between the first and the second dose. And it very well could be that you've been exposed and infected with COVID-19 before you got your vaccine, and you start to have symptoms, after you got your vaccine, but you'd already been infected before the vaccine. And so you absolutely can get infected with COVID-19 in between the doses.
I think that's something really interesting to think about and just consider as you go about this process of getting the vaccine, which brings me to my next question. How are we moving through those other groups? There's been reports of non-essential, I'm going to use that in quotes, people getting vaccinated before essential people. What should the public know about the process of kind of how Intermountain's been vaccinating people and how the state will kind of move forward through these groups?
Yeah, so keep in mind that Intermountain doesn't set who does and does not get vaccinated. That is not the role of a healthcare network or a hospital in the state of Utah or anywhere in the US. Who sets who gets vaccinated and when is the state of Utah. And so the Utah Department of Health sets those guidelines and says, this is our vaccination plan for the state of Utah. Intermountain Healthcare acts on behalf of the Utah Department of Health. That's the way this works in terms of public health measures. We are a partner with the Utah Department of Health, and we will vaccinate it based on their priority schedule. And so first priority were healthcare workers. And so that includes all healthcare workers. It's to ensure that the healthcare infrastructure is stable. And so that includes not only frontline physicians, nurses, respiratory techs, but it also includes people that support the infrastructure of the healthcare network. All our lab staff, our EVS staff, or our custodial staff, people that are not patient facing, but make sure that our healthcare networks can function and allow us to take care of patients. That includes billing personnel, people in analytics. All of those things are so critical to the healthcare infrastructure that they are first line. So it's all healthcare workers bundled together. So it's all of Intermountain's healthcare employees that is vaccinated. That's the first group. And we've actually now gone through and have vaccinated, as reported yesterday by Dr. Sheffield, 25,000 healthcare workers within Intermountain Healthcare. And it's at this point where if somebody hasn't got a vaccine, it's because they've chosen not to do it initially. And so that's pretty remarkable to get through that many healthcare workers that quickly. And now people are on to getting their second shot. So that's the first group. Now people are starting to vaccinate long-term care facility residents and workers. And so those are the really high-risk patients that if they get infected will lead to a poor outcome. Then is going to come, quote unquote, essential workers. That's just the designation of how they label it, and starting with paramedics, EMS staff, and teachers are coming hopefully very, very soon. And again, and this is just the waterfall, the cascade that has been set up by the Utah Department of Health in consultation with the CDC and ACIP. Once we get through that group of essential workers that teachers are going to lead out on, then comes those above the age of 75. After that comes those above the age of 65 or those younger with complicated medical conditions. Those are some really big groups. And that is going to be, again, directed by the Utah Department of Health. Of course, Intermountain is going to help with vaccine clinics, but we're going to be fully directed by the Utah Department of Health. And the speed at which that can happen is really going to be dictated on how our vaccine supply is from the federal government. And for those questions, I would defer everything to the Utah Department of Health in terms of what their anticipated schedule is.
I feel like you brought up a really great point about this package of people, which I think is something really interesting to understand. Yes, there's all these frontline caregivers that are patient-facing, but there's all those people in kind of like the back end scenes that are helping out and making sure that the health system runs properly. So I think that's a really great point to bring up, is when you hear these stories about people that are not necessarily frontline getting vaccinated, the reason for that is because if they were to get sick or ill, something would break potentially in the system. So I think that's a really great point that you brought up. I also want to define the word healthcare worker really fast. I have a friend who got vaccinated this past week, who in my brain is, she first told me, is not a healthcare worker, aka a frontline healthcare worker, but she's a therapist. And she ended up getting vaccinated this past week. Can you explain some other types of people that could potentially get vaccinated in this first healthcare worker wave?
Yeah, so it's really anybody who, as defined by the Utah Department of Health, is a healthcare worker. And even if they don't work for Intermountain or the University of Utah, which has vaccine clinics, the Utah Department of Health will vaccinate all healthcare workers, period. And so the Utah Department of Health has set up a process in which any healthcare worker, I think a therapist is a great example, right? Mental health is so critical right now in this pandemic that absolutely those people are frontline healthcare workers. They need to be vaccinated. They are seeing people face to face that could be infected with COVID-19, and they're an essential part to our system, our healthcare system, regardless if they work for Intermountain University or anybody else. And so those people can get vaccinated with the Utah Department of Health. And the process of how to do that is online. But Utah Department of Health will vaccinate any healthcare worker if they don't have access to vaccines within their clinic or within their healthcare organization.
The process that my friend documented as well seemed very smooth. It was a drive-through clinic that she went to, and it seemed like it was very simple, easy, and quick to do. So that's great news for when we get kind of to this next phase. And that people are curious on how it's going to work. So if you have friends who are healthcare workers, not specifically in the hospital setting, I think it's a good place to go to and to look to them and say, hey, how was the process for you? What was the experience like? Just so you know what to expect when it gets to be your turn.
Right. It's really encouraging them to see that they're setting up these drive-through clinics and really focusing on how do we do mass vaccination, as that's going to be absolutely critical for these really large groups of our population, age greater than 75, age greater than 65, where you're talking about hundreds of thousands of people needing to get vaccinated. It's really encouraging them to see that they're developing that infrastructure already.
Another quick question for you. With the hope that comes with this vaccine for healthcare workers, how are you and your team feeling, especially now that we have surging cases? What's the mood like now that the vaccine has kind of been there? And how is the vaccine impacting how you guys are interacting with your patients, if it is at all?
Yeah, so we'll start with the latter half of that, is that having a vaccine doesn't change the way I interact with patients at all. It doesn't change anything in terms of our reliance on personal protective equipment. We still have the same exact PPE procedures. We still use PAPRs for aerosolizing procedures. We're still using eye coverings or face shields and a mask. And, so nothing has changed from a procedural standpoint in terms of how we interact with patients with and without COVID. So zero has changed. What has changed is that it has given healthcare workers a bigger sense of safety. We were confident in our PPE, but always in the back of our head was, am I going to get sick? Did I have a lapse of PPE? Did I forget to wash my hands? Did I just touch my eyes? Am I taking this home? Is it on my clothes? And now as I hug my 2-year-old, it's now being transmitted to her. There's always that voice in the back of our heads, regardless if you're an ICU nurse or an ID doc or whatever it might be. That voice is now quieter with the vaccine. It has given us a better sense of safety. It's given us a better sense of reassurance that we are going to be safe and that we can sustain the healthcare system and infrastructure as we go through surge on surge on surge. And so I would say that it's really, it's taken a little bit of the fear of safety away. But it hasn't changed the fact that we are still saddened by the fact of how many people are being so negatively affected by this disease and how many people are losing their lives. That's not going to change, regardless if we've had a vaccine or not. What changes is that we just have a little bit more sense of safety now that we are vaccinated, and it's another level of protection for us as healthcare workers.
Someone else asked this question about requirements for surgeries. Is Intermountain going to be requiring the vaccine at all if you have a surgery?
No, absolutely not. We're certainly not going to require the vaccine for our healthcare workers at this point. We're clearly not going to require the vaccine for our patient population. So there's no requirements on this vaccine. One is that the vaccine is in very short order, so we can't do that from a operational standpoint. And it's a new vaccine, so people need to make their decision based on the science of this and whether it's right for them. And so at this point, there's certainly no requirements surrounding this vaccine.
I want to talk a little bit about antibodies for a second. Someone earlier asked us a question, how antibodies in recovered patients are seemingly declining over time, and immunity for those antibodies is lasting around 70 to 90 days. Are you seeing anyone reinfected multiple times with COVID-19, and how is this impacting the importance of getting the population vaccinated?
So we definitely have seen reinfections. Many times it's really kind of hard to distinguish reinfection versus prolonged viral shedding. But absolutely, we've seen a number of cases where I've been convinced, even with a very scrutinizing eye, that there has been reinfections, and some of those, reinfections have been severe. There haven't been many. I can definitely count them on my 2 hands, and so it's rare event, but we definitely have seen reinfections. The data up to this point would suggest that the vast majority of people that have been infected are quote unquote immune from a second infection for at least 6 to 8 months. As time goes through this pandemic, we're certainly going to be able to get a better understanding of how long that immunity lasts. But right now, it looks, based on a number of different papers, that people are immune for at least 6 to 8 months. There's always exception to that rule, right? So you're always, it's not going to be 100%. You're always going to see some exceptions of people falling out of that and getting reinfected. But we definitely see reinfections, but it's at a low level. The challenge that we're exploring right now through science is it an antibody level that determines your level of immunity? And so is it to the point where we can run an antibody test, look at your titer, and be able to determine whether or not you are susceptible or not? And we don't know that yet. What we know is that after 6 to 8 months, we feel comfortable in saying that you're probably immune during that phase. And so how does that affect vaccine rollout? People that have been infected absolutely need to get immunized. But we also know that people that have been infected are definitely protected at a pretty high level, likely at that 95% efficacy level, for at least 3 months. And so we are recommending people that have been infected, have had symptomatic disease, that they wait 90 days until they get their vaccine. And that is just to allow other people to get the vaccine, and people that need it more than the person that has a pretty high level of protection after a symptomatic illness.
Quick question along those lines too. So if you got infected in October, say, and is it possible that you could test positive now in January or within that 90-day period if you happen to have symptoms again and you decide to go get tested or you had a known exposure? Is it possible that your test could come back as positive?
Those are really, so the answer is yes. And that's a really challenging clinical situation to kind of sort through. We know that people can get infected and then shed the virus for weeks to months. And those people aren't infectious, they aren't contagious. When you look at the viral burden that they have in their nose where we're testing, that viral burden is very, very low that far out. And we know that that low viral burden doesn't lead to transmission. They're shedding just little bits of RNA that is left over from this infection. But their tests, the tests we have are so sensitive that it picks that up. And so in people that have had an acute infection, and now let's say a month later have new symptoms and get retested, and they're positive, it's really challenging to sort out, is that a new infection or is that continued viral shedding, RNA shedding from their upper respiratory tract? There's some tricks we can play to try to figure that out. We can look at some measures of viral burden called the cycle threshold, and that's something we can get off the PCR machine. We also look for other etiologies of the symptoms that they're currently having to see if we can find an alternative explanation. But that's a pretty challenging clinical situation and really needs some thoughtful evaluation by your primary care doc or an ID doc or whoever it might be. But absolutely, yes, you can test positive for weeks to months. And it's definitely more likely to test positive longer if you have an immunocompromising condition. If you're on medications that lower your immune function, you're more likely to shed longer.
That's interesting. One of the reasons I brought that up is tomorrow, Utah is a part of a multi-state testing day that is happening. We're encouraging people to sign up. It's a free testing day and anyone can go get tested. In your opinion, who should participate in this kind of a mass testing day? You mentioned the 90-day period of potentially testing positive again. So what are your recommendations for those who want to get tested, who should go get tested tomorrow?
Yeah, this is a demonstration project as best I understand it. I'm not part of this. It's not an Intermountain project. This is a demonstration project to see if it's possible to do large scale testing in a very short time period. And so the whole intent of this process is to test this system that is being developed by a nonprofit and to see if can we run 10,000 tests in a day and get the results back. And so these are tests that are PCR based tests. So this is a high quality test, but it's done on this massive platform to be able to get very significant volumes of testing done in a very quick period. So the turnaround time is 24 hours. And you can imagine how something like this would be useful, right? Governor Herbert in December came out with some new guidelines, and one of them was to increase testing, and that he wanted to see increased testing throughout the state of Utah after the first of the year, including in colleges and high school players that are in sports, et cetera. And so this could be a method to do that. And they're looking at, can we test over 10,000 people on this platform in one day, which would be, very significant. And the thought is they can do many more than 10,000. They could do potentially 50, 60, 70,000. And so it could really augment testing if a rapid, large volume platform like this could work. And so they're saying, if you want to get tested, go sign up. I'm sure you have a link that you can send people to. But absolutely, if you've had a recent exposure to somebody that's had COVID-19 and you want to know your status, please go get tested at this free testing event. We certainly welcome it, absolutely. But it really is a demonstration project that Intermountain is collaborating with to really kind of flex and test whether or not this large scale testing platform is doable and a potential solution for us here in Utah.
Thank you for that explanation. And yes, I will put the link up for people. Registration goes through noon today. We might extend it, so I will throw that link up for you guys. But the idea is to get 8,000 people tested tomorrow. There's 4 locations across the Wasatch Front. So it's not the entire state. There's a location in Orem, one in Ogden at McCady Hospital, one in Murray, and then there's one other that I cannot remember right now. But the link is everything. It has all the information for people. So if you're interested in that, you can go get tested. Before we move on to the new strain, there's a couple more vaccine questions I want to hit on. Someone asked if you are concerned that there's a lag between the number of vaccine doses that have been shipped to the state of Utah and the number that have been administered. And is there any concern from hospitals that we're keeping vaccines on the shelf too long?
No, I don't think we're keeping the vaccines on the shelf too long. We're certainly abiding by all of the storage criteria that's been defined by Pfizer and Moderna. And so I'm not worried the fact that we're having vaccines go bad. That's not a concern of ours at all. We've got 100% confidence in our pharmacy department who's managing this. So that's certainly not a concern. I would say that, yeah, vaccine rollout was, a little slow to start, but man, did we learn fast and did we start vaccinating, at high volumes right away in terms of our very targeted population of healthcare workers. And so what I anticipate to see is this very quick learning and being able to really flex vaccinations in time. And I don't think that moving forward that our limitation is going to be the vaccination effort. I think the limitation is going to be availability of the vaccine. And I expect that out of the Utah Department of Health as well, is that they're going to learn quickly and we're going to be able to vaccinate faster and faster and faster as these mass vaccination programs kind of roll out. I mean, if you just look at, Intermountain Healthcare at University of Utah, we vaccinated 25,000 people. We don't have clinics that do that. That wasn't something that, we had healthcare workers just waiting around to do that. And so this was a volunteer effort. We had healthcare workers coming in on their day off, volunteering at night, or, taking time during the week to go in and vaccinate people. And so this was a huge effort on the employee health aspect of that group. And then this incredible outpouring of support from healthcare workers to volunteer to give vaccines. And so I think we'll probably see something very similar from the Utah Department of Health, is calling on volunteers to help vaccinate individuals. And I suspect that once we have vaccine available at large quantities, that we'll figure it out and we'll learn fast and we'll get through vaccines quickly. Utah has done really well in big events like this. Not from Utah, but you look at the Olympics and some of these other things, and like Utah's very good at logistics. And so I suspect that UDOH is going to, really kind of rise to this challenge and be able to set up that infrastructure to develop it.
I think it's interesting to note too, I was listening to a podcast of a physician who lives in West Virginia. This is not a unique thing to Utah about the vaccines kind of being slower. It's definitely a US problem. So I think that's important to note, that a lot of states are trying to figure this out and figure out the infrastructure on how that'll work. And hopefully, as we learn more and more people are able to get the vaccine, it kind of speeds up that process a little bit. So it can only get better from here for that specific case. Another quick question for you around plasma. The American Red Cross said that there was a 250% increase in the need for plasma since October. The patients that are receiving that plasma are also will those patients who are receiving that potentially also get COVID-19 antibodies for this? And is that helping potentially keep patients from getting the vaccine?
Yeah, so as far as I understand, I don't know the process at American Red Cross or the other, places that deliver plasma. But the only way you're going to definitively know whether or not you're getting antibodies for COVID-19 in plasma is if it is tested COVID-19 convalescent plasma. And so just getting a unit of plasma for whatever reason, if you've got a clotting disorder, whatever the reason might be, just getting a standard unit of plasma by no means guarantees that you're going to get any kind of COVID-19 antibodies. What you would need is dedicated convalescent plasma from a recovered individual with COVID-19 to be determined whether or not you actually get antibodies. But keep in mind, convalescent plasma, those antibodies don't last in perpetuity. those antibodies are relatively short-lived. And so it's not like that individual continues to develop COVID-19 antibodies. That is a temporizing procedure to give somebody antibodies for a short period of time, and then the body turns over those antibodies. And so we're constantly producing new antibodies. And if you just get convalescent plasma, you're not going to have a long-standing antibody response. It's going to be short-lived. So by no means should it affect whether or not you get the vaccine or not.
I want to move on to the UK strand and also the South African strand that has started to appear. Can you just give us an update on what we've learned so far about those two strands, if either of them have made their way to the US, and what that means as far as vaccines and therapeutics?
Yeah, so there's the UK variant, and then there's the South African variant. They're different. They're different viral variants that have different mutations. And so these aren't the same things. They're two different mutations of the SARS-CoV-2 virus. So is the UK variant here in the US? Yes, absolutely it's here. The US hasn't done a lot of viral sequencing, and that's in contrast to the UK, which has done significantly more. And so we just don't know at what level is the UK variant playing a role in these surges. So we don't know if the UK variant is what's causing this tremendous surge in California, because it also happened to be at a time where we have holidays and change in public health practices and all of that. But absolutely, we know that the UK variant is here. I'd suspect we have it in Utah as well. It's just that the labs haven't done sequencing of the whole virus to determine whether or not it's here. And the reason I say I know it's here is that if you look at the individuals that have been identified to have the UK variant, these are people that have not traveled. These are people that are here in the US without any travel. So it's not like they went to the UK and brought it back with them. These are people that have acquired the UK variant while they've lived in the US. And so that tells us that absolutely it's here. How it's affected transmission here in the US is unknown. We don't know at what level is the UK variant circulating, what proportion of viruses are the UK variant. That's hopefully data we're going to see more and more. The UK variant, what we know right now is that it is more transmissible, but it does not cause more severe disease, and it's still sensitive to our therapeutics. And it appears that the vaccine generates an immune response that is still protective over the UK variant. So I say it doesn't cause any worsening disease, but it will lead to increased deaths. And the reason it would lead to increased deaths is because it's more transmissible. So more people will get it. More people will have, just by sheer numbers, severe illness, and more will die. And so by itself, it's not a more severe disease, but if it leads to more transmission, it's going to cause more disease, which will lead more severe disease and more hospitalizations. In terms of the South African variant, we're learning more and more about this. This does have a mutation in the receptor binding domain, which is part of the spike protein that allows it to attach to human cells, that may make it resistant to some of our monoclonal antibody therapies. A paper just came out last night about a potential resistance to a monoclonal antibody with the South African variant, so these escape variants. And so that's something we'll have to watch very, very closely. We have no idea if the South African variant is here or to what degree. We know it's spread to other countries, but not necessarily in the US. And so we'll have to watch that really closely.
And as far as just the general public, is it something that people need to really stress about if they contract that specific disease or that specific strain? Or is it, as we learn more, we'll kind of release more information to the public around that?
We'll clearly release more information to the public once we know more. But I think what should be emphasized is that the public health policies and procedures that we've been promoting since early in this pandemic is equally effective against the South African variant, the UK variant, or the standard wild type virus. And so social distancing, minimizing contacts, wearing a mask, all of those things will prevent infection, period. And should really be an emphasis and a focus. So if you're focusing on those, if you're really good at staying true to those types of recommendations, then I wouldn't be worrying about the UK or the South African variant. remember, this is what viruses do. Viruses mutate. That's part of just their life cycle. And so, just keep in mind, like, this is expected. We expected viral mutants to arise, just like we see mutations in influenza. It's just that this has taken longer, which just means that it's a little more stable of a virus. And so this is expected. I wouldn't say I'd be, too overly concerned. I would say stay true to your public health practices. And as we learn more, we'll bring you more.
That's great advice. Last question for you. This is interesting. If you've gotten the vaccine, is testing for COVID-19 still going to work for you? So if for some reason you have the vaccine and you do end up contracting COVID-19, will your test come back positive?
Yeah, absolutely. Yep. So regardless if you have the vaccine or not, but if you got the vaccine and then develop symptoms of COVID-19, whether it be a month or two after, absolutely go get tested. So whether it be the nasal PCR, the saliva test, an antigen test, all of those will still be positive if you are infected post-vaccination. And so absolutely 100% go get tested if you have symptoms of COVID-19 after the vaccination. These tests look for the RNA of the actual virus or antigens of the virus. And so if you have active replication, those tests are going to be positive, regardless if you've been vaccinated or not. Vaccines may cause less severe illness. So we saw that in the Moderna trial, in the fact that even in people that got infected post-vaccine, those symptoms were less than those in the placebo group and less severe. And so, but I would say absolutely 100% go get tested if you've been vaccinated or not and you have symptoms of COVID-19.
Well, Dr. Stenehjem, thank you so much. We really appreciate the update for this week. And if you in the community have any questions around COVID-19 and would like to see if you qualify for a test, you can go to intermountain.com/COVID testing. There's just a quick survey that you fill out with a couple of questions to qualify you for that test. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. I put the link for the demonstration day in the Facebook Live on our Facebook page. If you have any questions around that, you can leave them in the comments as well. Dr. Stenehjem, as always, thank you, and we'll talk to you next week.
Sounds good.